Hi, everybody. Welcome. My name is Michael Valaire, and appreciate you being here for this presentation of Health Literacy 101 and Introduction. In general, I give this presentation for those who are new to the field of health literacy, or for those who just want a little bit of an update. And so without further ado, here we go. So what are we going to talk about today? We're going to talk about health literacy. We'll start off with some definitions. What comprises health literacy? What are the components? And then some examples of how this plays out in real life. We're going to take some data from national surveys. These surveys are a little bit old, but they're really the best data that we have. And subsequent studies have shown that these numbers have not really improved greatly. So these numbers actually have validity. We're going to watch a little video clip called Health Literacy and Patient Safety, Help Patients Understand. This was produced by the AMA Foundation years ago, but I've always found it very valuable for people to get that sort of perspective from the person who has some literacy issues. And it's a very powerful video. It runs about 5 or 6 minutes long. We're going to look at some statistics, prevalence of health literacy, and the costs of health literacy, both from a systems resource perspective and also the human toll that limited health literacy can take. And then we'll look at an example of whether we ought to screen for health literacy. Okay, let's go ahead and jump in. So let's start off with some definitions. Literacy, people always ask, well, what's the difference, literacy and health literacy? They are overlapping concepts, but they are actually distinct in terms of the definition. So for literacy, lots of different definitions we could use. This one works pretty well. Using printed and written information to function in society, to achieve one's goals, and to develop one's knowledge and potential. It's essentially your ability to read and write and function in a society, to be able to understand how to navigate, how to purchase things, interact with one another. Basically, as I said, kind of your ability to read and write. Health literacy, now there's a lot of different definitions here. It really is an interaction between the skills of the public and the demands and expectations of the health sector. So when those things meet, we kind of have our optimal situation. But quite often the demand of the healthcare system is way up here, and the skills of the public, what we're asking people to do, is really well below what we're kind of asking, because many times we put really unrealistic burdens on people, and we'll see some examples of that in just a moment. So here's a definition that's been around forever, and really I think it's generally acknowledged that this one is a little bit out of date. The degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. On its own, it's not bad, but the problem is that it puts the onus and all the focus for health literacy directly on the individual. And there's no element of responsibility on the system itself. So these two definitions are from Healthy People 2030. In this latest iteration of Healthy People, they decided to do two definitions, one for personal health literacy and one for organizational health literacy. So here's the definitions. Personal health literacy is the degree to which individuals have the ability to find, understand, and use information and services to inform health-related decisions and actions for themselves and others. So you can see quite a bit of reference back to that original definition. But then there is also this companion organizational health literacy definition, which is the degree to which organizations equitably enable individuals to find, understand, and use information and services to inform health-related decisions and actions for themselves and others. So the key part here is that phrase, equitably enable individuals. And so we're going to get into that in just a little bit. But again, we are the healthcare system. We're the ones with the knowledge. We're the ones who work in this space all of the time. Patients and people coming into the healthcare system, they spend a fraction of their lives interacting with healthcare and the healthcare system. So the language, the jargon, the way to navigate the system, understanding how to take care of yourself, issues of self-efficacy, understanding how to take medications, how to manage chronic illnesses. All of these things are very, very complex concepts. And quite often, we as the healthcare system really don't do a great job in terms of explaining how those things work in terms that people can actually understand and act upon. So let's press on here. Another way to think of health literacy is that it's a state, not a trait. And here's a good example of that. So imagine you've gotten, you had a test, a scan or a blood test or an X-ray or an MRI, whatever it was. And the doctor says, come on in and we'll talk about your results. And you walk in and you're in the exam room and they say, you know, I'm really sorry, but the results of your test came back and it appears that you have cancer. And so I can guarantee you right at that moment, your health literacy is going to drop because your mind is not going to be focused on what that healthcare professional is saying. Your mind is going to be going every other which way. Oh my gosh, what does this mean? Am I going to live or die? What about my family? What about, you know, everything else? How am I going to make it? What am I going to do? Am I going to be okay? So all of a sudden, that cognitive engagement that you would normally have in that situation and being able to understand and have a productive conversation, it really kind of flies out the window. And so this is what we mean by health literacy as a state, not a trait. And we'll see some of the other things in a short bit that tend to affect and modulate health literacy. So health literacy components, what all is involved here when we're talking about health literacy? So we're looking at reading and writing, we're looking at listening and verbal communication skills, and this is between patient, provider, whatever term you want to use, healthcare professional, healthcare consumer, whatever the term is that you're looking at. These are really two-way streets, conversations. I mean, this presentation you're watching is one way. I mean, obviously I'm recording it and there's no way for you to ask me questions and have any kind of dialogue. So this is kind of a didactic one-way lecture presentation. That should not be the way things are in a healthcare setting. We should be really looking at what does that exchange look like? There's information given from the healthcare professional to the individual. There may be some questions asked. If the healthcare professional is using effective tools such as teachback, they may take a pause, should take a pause, and check to see what the understanding is. And there's a whole process around that, but it's a way to have an individual repeat, or not repeat, but explain in their own words what has been told to them so far. What do they understand? And then the healthcare professional can evaluate that based upon what the individual has said back and identify those gaps and take responsibility for any miscommunications and try to communicate that in a different way so that you teach to understanding. Numeracy, this is the ability to deal with numbers, remarkably difficult. We'll see the statistics on numeracy, also known as quantitative literacy, when we look at statistics in just a moment. But numeracy really involves things like computational skills. If you're asked to take 2 pills 3 times a day, what's your total number of pills? If you are taking a medication once every 4 hours, how many doses should you take? There's dosing charts where you have to see weight and age or things like this, especially for children. To be able to really kind of figure those things out requires a higher level of numeracy. And then also interpreting and evaluating risk. And these are things that are very important when you need to make some decisions based upon what kinds of treatment you want to have, what you want to do in certain clinical situations, choices of medication. You know, the famous example is this pill works in 1% of the population, and it's only $5. This pill is twice as good. It works twice as well, but it's $100 each. Well, when you say it works twice as well, you're talking about an increase of 1% effectiveness to 2% effectiveness. So really not a big gain, and the cost obviously is a major factor. But there's a whole set of language and framing issues around this notion of risk and making decisions around that we as the healthcare system have a real responsibility for making sure that these things are discussed in a way that means something to the individual. And then, of course, self-efficacy, your ability to take care of yourself. If you are diagnosed with diabetes or asthma or cancer, there are certain things that you need to do to maintain your health or maintain as strong a sense of health that you possibly can. And for things like diabetes, to keep your blood sugar in a certain range and make sure that you don't suffer some of these really bad side effects that can come from that. Those things are remarkably difficult to teach, and they really take a one-on-one approach, testing and making sure that the language that you're using, the teaching aids, the pictures, the descriptions, the brochures, the videos, whatever it is that you're using to teach, that works for the recipient. Some people like to read. Some people learn best by hearing. Some people by watching. Some people need a combination of all of those things. So it's really that notion of self-efficacy is a component of health literacy, and there's a major component that puts the onus on us as the healthcare system. So some other things that play into health literacy, culture and belief systems, who you are and how you grew up and what you believe in. It's not necessarily the same as all those things for me or for anybody else. And quite often in certain cultures, there are norms that we as the members of the healthcare system need to make sure that we understand. This is a part of what we would call cultural awareness and cultural competency. And so there's a really great book that illustrates this. It's called The Spirit Catches You and You Fall Down. And it's by Ann Fadiman. And it tells the story of a family, a Hmong family, H-M-O-N-G, Hmong family in Northern California. I think this was back in the 70s, possibly early 80s, but again, about 40 years ago, 40 years ago. And the little girl was, she had a seizure. She was like 2 or 3 years old, I believe. And she had a seizure. And so the family took her to the local community hospital, and she was diagnosed and said that she had epilepsy and she was going to have these seizures and she needs to take these pills. Well, the family believed that the source of her illness was a spiritual reason or spiritual cause, that she had suffered a fright from a loud noise, that her spirit had left her body, and that an evil, malevolent spirit had captured her spirit when it came out. And so now she had this affliction. And when you translate from Hmong, how the family named her condition was the spirit catches you and you fall down. And it really the book really talks about the clash between these two systems, where we had the Western medicine system saying, this is what it is and this is what you need to do, and the Hmong family saying, this is what it is and this is how we need to treat that. And there was never really a meshing of those two ideas or those two cultures to be respectful of one another and understand one another's position and come up with something that worked together for both of them. So again, some other considerations are this mismatch between what we are asking people to do and the skill level that they bring into that equation. Some things are fairly simple. You could say, Valère, you need to, stop drinking sodas. I don't really drink sodas, but if I were drinking a lot of sodas and I was pre-diabetic, they might say, you need to stop drinking sodas. Okay, that's pretty straightforward. The doctor could say, Valère, you're overweight, you need to lose 40 pounds. Okay, well, how do I do that? So we need to make sure that we understand what it is we are asking and that we test in whatever way we can, so to get a sense that the individual with whom we're interacting understands what it is we're discussing that's of importance to them, and that what we're asking them to do is something that they can act upon. And then, of course, all the other things about encouraging questions and assessing understanding through tools like Teachback and those sorts of things. This mismatch of reading materials, reading levels and reading materials is one thing that in health literacy, we tend to put quite a bit of emphasis on. It's not the only thing. It's certainly, though, an important component. And so if somebody is reading at, let's say, a 5th or 6th grade level, and we give them a brochure, here, take this brochure. And the brochure is written at a 14th, 16th, 18th, 20th grade. Yes, those levels actually exist. Reading level, there's a mismatch there. And the likelihood is that thing's going to go in the garbage or in a drawer somewhere, and it won't get read because it cannot be read. And so making sure that things are, readable, accessible, understandable, and actionable in our written materials is very, very important. Health literacy has very strong relation to health disparities. This is especially true in areas such as access to healthcare. If we don't understand how to get and use and keep a health insurance policy, whether it's Medicaid, Medicare, or private health insurance, then we have a problem. We are now that person is now being put at great risk because they don't understand how to use that policy. And if they did understand how to use that policy and were able to use it, that's a lifesaver. And if they can't, then that's a health disparity that they are experiencing. Health literacy also has strong relations to safety and to quality. These are pretty evident things in terms of instructions, warnings. Take this, don't take that. If you take this medicine, don't do that. When you leave the hospital after surgery, make sure you do A, B, and C. Don't do D, E, and F. Those things are remarkably closely tied into safety and to quality care issues. And when we don't practice, ensure that there is understanding, then we're getting into these issues of safety and quality. So here's my buddy with one drink. You know what you mean, but does he? So I guess what we're really, so he says, my doctor said only 1 glass of alcohol a day. I can live with that. I believe I would be in a coma if I had half of what was in that glass. The point here is just because something is clear to you, it only means that it's clear to you. It does not mean that it is clear to those whom those you're speaking to. So this gentleman, of course, this is an exaggeration and a bit of a joke, but the phrase was, you can have 1 glass of alcohol a day, but there was no indication of how much, what is a glass? Is it, a 1 ounce shot of liquor? Is that a 4 or 6 ounce glass of wine? Is that a 12 ounce bottle of beer? What does that actually mean? So those sorts of things it is our responsibility to think forward and make sure that we're being very, very clear. You can have 1 shot of liquor or 1 6 ounce glass. I can't remember if it's 4 or 6 ounces of wine, or 1 12 ounce bottle of beer per day. That's if the doctor had said that, then obviously this situation would not have taken place. So here are a few little potential scenarios. And actually, I think these are for real. So an 89-year-old man with dementia is diagnosed with an ear infection and is prescribed an oral liquid antibiotic. His wife understands that he must take 1 teaspoon twice a day. After carefully studying the bottle's label and not finding administration instructions, she fills a teaspoon and pours it into his painful ear. I cannot fault the wife in this scenario because we, as the healthcare system, did not say take by mouth or swallow or anything similar to that. It just says take 1 teaspoon, and he's got an ear infection. Here's the medicine. Here's where it hurts. This does not seem like an outlandish stretch to see that mistake could be made. And these things happen all the time. Here's another one. Mr. G, 45, Hispanic immigrant, native Spanish language speaker, has a job health screening. He is told his blood pressure is high and he can't work until it's controlled. He's given a beta blocker and a diuretic and instructed to take each once a day. That's what's on the prescription bottle of each one. Take once a day. 1 week later, he presents at the emergency department. His blood pressure is very low and he's dizzy. The doctors can't figure out why. A Spanish speaker in the ER or in the emergency department asks him how many pills he took each day. 22, says Mr. G. In Spanish, once means 11. And so here's a person who in their language only recognized 1 word on that label. and that was once, we say once, which means one time. He saw once, which means 11. So he took 11 of each one. It begs the question, can low health literacy or limited health literacy kill you? I would submit that yes, in fact, that certainly could. Here's one more little scenario at a teaching hospital. Intern writes in a patient's problems section of the medical chart, speaks no English. The attending physician writes a note back in response. Your problem, not his. Because somebody does not speak our language, that is not a problem. That is not a patient problem. That is a barrier. That is a challenge. That is something that is keeping us from communicating. And so what we really need to, the way we really need to look at this is to say, all right, so this person doesn't speak English. We here at the hospital hopefully have a language access policy and program. So if they need somebody to come in and interpret, whether it's by sign or by some other language, that you would bring in that third party and that they would interpret the conversation between the clinician and the patient and their family members, if that's who all happens to be there. Here's one little quick bit of information in healthcare. There's a distinction between how you take the spoken word from one language to another. That's called interpreting. If you change the words from one language to another in written format, that's called translating. So make sure you understand those two concepts, translation and interpreting. They are distinct entities, and it's important to understand those distinctions. So I mentioned earlier on, we were going to take a look at a video. This one, it's as I said, it's kind of old, but it really still does hold up. And what I would like for you to do as you're watching this video, it's a bunch of clips. Listen to the stories that the people are telling. There's some titles on there. It'll give you their name, what they do for a living, and at what grade level they read. So all of these individuals telling their stories have some challenges with literacy, and they really try to focus on that. And most of these are really how that challenge with literacy relates to their being able to take care of themselves in terms of their health. So I'm going to go ahead and start this. I'll turn off my video so you can focus on the real video. Okay, here we go. When they did give me medicine, I just didn't understand them, and I didn't have the nerve to ask them the right way of doing it. I just didn't have the nerve to ask them. I didn't want anyone to know I couldn't do it. I would show up on Tuesdays instead of Thursdays for the appointment. I would be exercising the wrong side of the body. I had an abscess in the ear one night. Well, I had to fill out forms and I didn't fill out, so I didn't know. I come back home. I ended up having to go to the emergency room that night because of the emergency. Can you imagine what it's like? You being a patient and sick, and you know that you have limited skills, okay? And you're talking to an intelligent doctor like yourself. And these people are using words that you really don't know because they're not speaking in layman's terms, okay? Right. Most doctors are just presuming that everybody's intelligent as they are, and that is just not the case. So what you do, you come out of that room, that examination room with this intelligent woman or man thinking, God, I hope I don't make a mistake with my medicine because I did not understand anything he or she saying to me. One capsule. Oh, this is actually twice daily. Okay. So how would you take this? When I see it's not only I tell you how to take it. It says take it twice daily, but it don't say what time to take. Put it one is one day. It's like the medicine you do in the morning. I think that and the little pill. Well, this is the plasma, and this is lithium in it. Yeah, that's lithium. Okay.
And what do you take that medicine for?
Don't ask me, he puts
Okay.
it on there and I just take it.
Okay,
Anything he tells me to take, I'll take it.
okay. So you trust him?
Oh, you better believe it, my life.
Hypertension means, if I asked you what that was? Because when I look at this, I think, well, maybe you have hypertension and I've been taking care of that for a long time.
Hyper, hyper.
Like you're hyper?
Mhm.
What does being hyper mean to you?
That's where you can't be still, you always gotta be doing something.
Do you think I think you're hyper? You have hypertension?
I don't know, that's what I consider it
Okay.
to be in,
But you know you have high blood pressure.
yeah. Mhm.
Okay. But hypertension doesn't mean the same to you.
Mhm.
So if I ask you if you have hypertension, you're gonna just think, I think you're jumping around on a chair or something like that. Something different.
Being hyper, you know.
Okay. All right. Well, I haven't done a very good job teaching you what hypertension is, because I think you take that medicine for hypertension. And that's one of the things that I try to work with you on is your blood pressure. And high blood pressure and hypertension to us is the same
The
thing.
same thing.
At approximately 30 or 31, I went into the gynecologist and complained about part of this not working correctly. And he said, we can repair that. Great. I didn't ask all the right questions. When I showed up 2 weeks later at the admissions office at the hospital, they put enough papers in front of me. I'll bet there were 5 papers that I needed to sign. Well, I wasn't going to say, excuse me, but I don't read really well, and I certainly don't read fast, and I'm concerned with some of these words. To me, it was lines and circles over sheets and sheets and sheets. And I wasn't going to reveal my sense of stupidity. So I signed every way they told me to sign, never read it. And then a couple weeks later, in the follow-up office visit, the nurse said, how are you feeling since your hysterectomy? Now, I acted as normal as I could. Inside, my mouth fell open, and I thought to myself, how could I be so stupid as to allow somebody to take part of my body, and I didn't know it.
If you have a reading problem, you go to the doctor. That can be very scary. It's like a nightmare. You walk in that office, and most people, if you realize, first thing you're gonna have to do if that's your first visit is start a form. Your heart beats real fast. You're scared. You don't know what to do. You want to turn around and walk out. I have.
You have panic attacks. Did I do it right? Is this done right? Am I imagining things? Do I go back over and check it again? I've caught mistakes that I made, simple mistakes.
It paralyzes your thoughts completely to think that you may say something or something is put before you to read and you can't read it. I mean, you live with that on a daily basis.
People sooner or later will discover, and that is your most greatest fear. What day is it going to be when somebody discovers you can't read?
I would get mad about something and blame them that this is not the right place for me, you're not respecting me, and walk out. And it had nothing to do with that. It was just I need to cover that I couldn't read this. I didn't want them to know that I'm walking out because I can't read.
So you found solutions that sort of make it work and hide the real problem.
Yes.
That others won't notice.
Right.
Doesn't that take a lot of your time?
Yes.
Doesn't it take a lot of effort?
A lot. Very emotional. Yep. Yep.
I am married to an engineer now, and this man has some health issues, so we are in the doctor's office from time to time. We will walk out of the doctor's office, and my husband, with all of that left brain intellect, will say to me, what did the doctor say? What am I supposed to do? I don't understand.
One of the things that you can do if you have a really bad pain, where you can't stand on it and it's really getting in your way, is to use what I call, this is my little pain protocol here. It has ibuprofen, which decreases those little cells I was talking to you about, the inflamed part, and your Tylenol that just works on the pain. and the I is for ibuprofen, and T is for Tylenol. And this just shows you how to do it over the course of the day. For breakfast, lunch, and dinner, there's an I, so you use ibuprofen. Because you have to have something on your stomach
That's right.
with that one, because this one will irritate your stomach. So in between meals and at bedtime, you use the Tylenol. This way you get something every 3 hours. You don't overdose on either one. So it's IT, IT, IT. And if you do that for a couple of days when it's really bad, then you can just go back to your regular regimen. But this usually breaks the pain pretty nicely. So I know you have a lot of friends with arthritis. How would you explain it to them?
Well, for breakfast, I take I. 10 a.m. I take T. Lunch, I take I. 3 p.m. I take T. I at dinner, and T at bedtime. Is that correct?
That's gonna work just fine.
Ms. Dolson, who didn't
Okay, we're back. Now, normally when I'm doing this presentation live, this is where I call on people to share, whether they want to or not. But I think during this video, there were some really some very heartbreaking stories and some very illuminating types of stories. You know, at the beginning, we had the woman saying, I didn't take my medication right. I admit to it. And you know, that word admit always kind of sticks with me, because you think, well, when you admit to something, you're saying that you kind of, you know, I broke the glass. I admit, you know, I admit it. I ran the red light. I admit it. You know, that you did something kind of with, you know, an intent to do something wrong. And frankly, just because you don't understand the instructions that are written on a prescription label is not, you know, kind of premeditated at all on your part. There's the stories of how everybody, these individuals with limited literacy skills have to hide that. The gentleman who says, you know, your greatest fear is the day that people find out, and they will find out. This is, he just sort of, you know, admits that it's pretty much a foregone conclusion that someday, and it's just that pressure of having to live with that. I have to say, I can't imagine what that would be like, just having that fear in you on a daily basis of, you know, when everybody would, or when anybody would discover that. And then of course, the woman who had didn't realize it, but had a hysterectomy because she couldn't read the consent forms. And consent forms, this is a major challenge. This is a major issue. There's been a lot of work done in this area and a lot of advances that have come to that, but it's still a major issue. And so I hope at least that video gave you a little bit of insight into what it feels like to walk in somebody else's shoes for a little bit. It's very difficult, very, very, very difficult. So let's move on. Let's take a look at some statistics of literacy and health literacy. As I mentioned, 2 studies. These are old studies. The 1992 NALS study, the National Adult Literacy Survey, which did strictly literacy levels, and then in the 2003 NAL, National Assessment of Adult Literacy, they added a health literacy module. So the statistics that we get, that we use here, are from this 2003 study. Now, there are no further NAL studies planned, but there is the PIAC that is done internationally, and that assesses literacy skills in countries all around the world. So there's the URL. Go ahead and take a look at that if you're interested, and compare literacy skills, and you can see really there's not been an awful lot of progress over the years. But let's jump into some statistics here. Okay. So the literacy levels that we're using are these 4 levels: below basic, basic, intermediate, and proficient. You can see the descriptors there of each one. When we talk about the healthcare system and people's ability to navigate that healthcare system, we really need to fall into this proficient level. Anything less than proficient, there's going to be a lot of components that we miss, that we don't understand, that we are unable to act upon. And so to really effectively navigate the healthcare system, we need to be in that proficient level. So from the NAL, the 2003 NAL, These are the literacy findings. We'll look at health literacy in a moment, but these are the literacy findings. So what percent of the US adult population fell into the bottom two categories? So remember, there was below basic, basic, intermediate, and proficient. So the below basic and basic, those are the bottom two categories. And in terms of prose literacy, which is just your ability to read sentences and paragraphs, just think about reading a book, a magazine article, a brochure, or something like that. Prose literacy, 44% of the adult population fell into the bottom two categories. Document literacy, this is your ability to find information on a page, whether this is a dosing chart, it's a map, a BMI chart, some kind of form where you have to fill in information or get information. Document literacy, even lower, 34%, about 1 in 3 fell into the bottom two categories. And then quantitative literacy or numeracy, which we talked about earlier. This is your ability to use numbers to understand and evaluate risk, those sorts of things. 55%, more than half of the adult population are in the bottom two categories in terms of quantitative literacy or numeracy. So now let's take a look at the health literacy statistics. Those were the literacy, these are health literacy. 36% of the adult population fell into those bottom two categories. You can see the split there. So little more than 1 in 3 individuals are in the bottom two categories. Here's the one that always strikes me, and this is the one that kind of I use all the time, and if people need any kind of persuasion about why we need to invest the effort in health literacy that we do. 12%, which is about 1 in 10 adults in the United States, are considered proficient in health literacy. 1 in 10 US adults is considered proficient in health literacy. So that means almost 9 out of 10 are really not able to effectively and completely navigate the healthcare system, take care of themselves, make those decisions, obtain the information, et cetera, to be able to be considered health literate. About half the population had intermediate health literacy. And then no big surprise here, women's average health literacy score was 6 points higher than men, and 4% more men fell into the below basic category. So there you are. Now this next one I want to be really careful about. Our heading says who has poor health literacy. And what we really need to understand here is that in each one of these groups, it doesn't mean if you are 65 years of age and older that you have basic or below basic health literacy. It means members of that group tend to have a higher incidence of low health literacy, okay? So we have to be very careful about that distinction, because you can't just look at somebody who is 70 years old or 80 years old and say, oh, poor health literacy. Not necessarily true. That group, as I said, the incidence in each one of these groups tends to be higher, but it doesn't, there's not an automatic correlation between the two. So we can see the statistics here. Nearly 60% of those who are 65 years of age or higher fall into those bottom two basic, below basic health literacy. The tendency is that those who get health insurance from an employer tend to have higher health literacy. Those on Medicare or Medicaid or who have no insurance tend to have lower health literacy. Hispanics, representing about 16% of the adult population, represent about 35% of those in below basic health literacy categories. And those living at or below the poverty level, which is about 17% of the adult population, they represent about 43% of those in the below basic health literacy. So you can see in each one of these categories, there is a tendency for individuals in each one of those groups to have limited health literacy. Does not mean because you're in one of these groups that you automatically do. Can't stress that enough. And then studies have shown 75% of those who self-reported poor health fall into the below basic health literacy category. So why is this a BSD? BSD, oh, that stands for big stinking deal. So why is this a big stinking deal? Why does health literacy matter? For a lot of reasons, and let's go over a couple of those right now. Those who have limited literacy skills they tend to report, or limited health literacy skills, I should say, they tend to report poorer overall health. We saw that on the previous slide in terms of the statistics. Their ability to manage chronic diseases that's a challenge, to be able to manage those, because we are the ones, as the healthcare system, we're the ones who need to explain that. And if we don't do a great job, and our demand is up here, and the capability is down here, that's a mismatch, and we are not going to be communicating. And so the individuals with limited health literacy skills would tend to have a poorer ability to manage those chronic diseases. They also, as a group, tend to have poorer outcomes, are less likely to understand their diagnosis. What does this mean if you're telling them I have asthma or diabetes or high blood pressure or anything else? They're less likely to have screening and preventive care. Again, this kind of goes back to that issue that we talked about with respect to understanding how to use and keeping and using a health insurance policy, whether it's Medicaid or Medicare or private health insurance, anything along those lines. Health insurance is a pretty complex concept, and so to be able to understand that it's a health literacy issue. They tend to present in later stages of disease because, again, we learn what are some warning signs, and quite often, we don't take those warning signs. When you're at a certain age, you need to start having certain screening tests, and of course, with limited health literacy skills, you don't get and understand and act upon those particular messages. Those with limited health literacy also are more likely to be hospitalized, and when they are discharged, less likely to understand very complex discharge instructions, and so they're more likely to be rehospitalized. So again, those are some of the kind of reasons and statistics, or facts, I should say, about those with limited health literacy. Let's take a look at some resource and cost and dollar issues here, because we'll start to connect some of these threads here. Very early study by Robert Friedland at Georgetown showed that about $73 billion each year is spent unnecessarily because of health literacy issues. A later study by Vernon and colleagues at University of Connecticut bumped that up to about between $106 and $238 billion in unnecessary costs annually. A lot of people dispute the veracity or the correctness of any of this data. I think what's not in dispute is that there's an awful lot of money spent each year because we, as the healthcare system, are not we don't take health literacy into account and really try to communicate as clearly as possible. What that number is, there's always going to be a lot of debate about that, but the fact remains there's quite a bit that is spent unnecessarily each year because of this. Then we look at things like the cost of chronic disease. About $1.1 trillion in direct treatment is spent each year. And then if you add in the indirect costs, which would be missed work time, disability, all of the other associated types of costs, that number inflates up to $3.7 trillion. And that's about 20% of our gross domestic product. This is a staggering number. 60% of Americans live with a chronic disease, and 40% of those have two or more. 90% of those 65 years of age and older have a chronic disease, and 77% of them have two or more chronic diseases. And then about 7 out of 10 annual US deaths are due to chronic disease. So we can start to, as I said, start to connect some of these dots. So especially with this statistic here, the 90% of, yikes. Sorry about that. This statistic, 90% of those 65 years of age and older have a chronic disease. So the need for this particular age group to understand how to take care of those chronic diseases is quite high. But you recall from the previous slide, those 65 years of age and older as a group tend to have a much lower health literacy capacity. I think it was 60% fell into the bottom two categories. So at the end of the day, those who really need to understand those instructions are the ones who are least suited or least able to be able to follow instructions that are not put out simply plainly in an understandable, actionable fashion. So a few more statistics. About half of the American adult population is not reading above an 8th grade level. And most patient education materials are written beyond the recipient's ability to read. I think on average, a while back, somewhere between 9th and 12th grade reading level or higher. 25, so from this next one was from a study published in JAMA, 26% of individuals could not understand when their next appointment was when it was written on an appointment card and given to them. 42% could not understand the instruction, take on an empty stomach. And 60% couldn't understand a consent form. I believe that number is actually a lot higher. I consider myself to be pretty well educated, and I've read through some consent forms, and there's a decent number of places that I still stumble on and have to ask questions. So, and then a few more facts just to sort of stir in. 381 languages that are spoken or signed in the United States. 47 million foreign-born people who live in the United States. 60 million Americans who speak a language other than English at home. 24 million Americans who have limited English proficiency, and 75 to 90% of patients in the 2 lowest reading levels describe themselves as being able to read and write English well or very well. So this last statistic to me is really probably one of the most insidious ones, because you can't just ask somebody, so do you read and write really well? Sure I do. As you saw from that video, there is tremendous shame associated with limited literacy skills. People are simply not going to tell you, hey, I'm here for my appointment. By the way, I can't read and write. That's just very unlikely to happen. And when you have nearly 9 out of 10 patients who fall in the bottom categories saying that I can read and write English well or very well, you'll use that as a cue to say, oh, okay, well, I can just talk in normal language like I do with all of my other healthcare colleagues, and I'll use jargon and long sentences and a lot of subordinate clauses, and I'll talk really fast, and I won't take time to ask questions because you said you read and write very well. So let's just get this going, because I got another patient I got to see in a couple of minutes. So I got a lot of information I got to give you, blah, 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 blah. And guess what? That's just going right over their head. And so that whole interaction was for naught. And these other ones regarding language, what language people speak at home. As you recall earlier on in our presentation, we talked about the intern who wrote in the patient problem section speaks no English. Guess what? That's not a patient problem. It's just a challenge. And so when we have this significant portion of people who don't speak English as their first language or have limited English proficiency, it's a barrier. It's a barrier. There's no judgment there. It's just a barrier. And it's our responsibility as the healthcare system to deal with that barrier. How do we get around this? Language access programs is one great way, lots of other different strategies, but it's just something that we as the healthcare system, as the individuals who are the keepers of the knowledge and the ones running the healthcare system, it's our responsibility. We're the ones who need to stand up and take responsibility and say, you know what, we're the experts. And so we need to make sure that we are being very clear and concise. A few other issues, cognitive impairment, whether that's just as a result of age or disease process or medication, which is on the list there. Quite often, we're just not able to focus and concentrate or understand things that that somebody might think that we would be able to understand. Hearing and visual impairment. If you're in that doctor's office and you have issues with hearing, and that doctor is talking very quickly, everything sounds muffled. If you tend to read lips or take visual cues from that, and they're turned away, they're looking at their computer, which unfortunately happens quite a bit. This is going to affect the quality of that interaction. Medications, as we discussed, stress. You heard the story from the person in the video who said her husband, with all that left brain intellect, walks out of the doctor's office and says, what did he say? Studies show that would tend, by the time you hit the door and walk out, you've probably forgotten about 50% of everything that was communicated during that primary care visit. And this is not just for primary care. This is about reading information. This is about just understanding any concept within the healthcare system. And then we talked about this, the shame around, around limited literacy, I should say. 78% thought they should just hide it or cope, and you saw that in the video. 77% never told their doctor. 2 out of 3 never told their spouse, and 19% never told anyone. So again, these statistics are they're sobering. They're very sobering. Then there's an issue where people are like, well, let's just do screening tests, and let's find out who has limited literacy, and then we can just talk to those folks one way, and the folks who are really educated, we don't have to worry about. What a headache. My recommendation, and the recommendation of a majority, I would venture to say, of those who operate and work in this field, is we should use what we call universal precautions, which is essentially treat everybody as if they're low literate. And that doesn't mean to be condescending. If anything drives me more bananas, is when somebody says, oh, let's take this and dumb it down. We're not dumbing things down. We are using plain language. So what's plain language? Plain language is language that we use to describe something so that somebody understands it the first time they hear or read it. Living room language is another example. These are all just ways to communicate that we don't have to try and prove we're really smart by using big words. We can use simple concepts, short sentences, 1 or 2 syllable words, stop for a moment and assess and make sure that people are staying with us, because healthcare is pretty complex stuff. So this is what universal precautions is really about. It's just removing barriers. Again, health literacy really is about identifying and removing barriers so that we're all operating on that same field, that we achieve something that we'd like to call health equity, right? That everybody has equal access, that everybody has an equal ability to thrive, and it doesn't depend upon any particular factor. Who you are, where you live, where you come from, how much money you make, whether you work, what color your skin is, where you were born, where your family comes from, your gender, any other issue. None of that matters. Everybody should be able to access and use quality healthcare and be able to live a healthy and happy life and thrive. If you do decide you want to screen, 2 of the tools that are available, one's called the MVS, newest vital sign, not so new anymore. Barry Weiss and colleagues developed this. It's an ice cream nutrition label, and there are 6 questions that take about 3 minutes, and you can get an assessment of where somebody's literacy skills are after that. Or Lisa Chu and colleagues, who had a series of 3 questions, and this one tended to test the best. If you ask somebody, how confident are you filling out forms by yourself, that tends to correlate pretty highly with where their literacy skill levels are at. So again, when this issue of screening comes up, the recommendation really is just use universal precautions. Be clear, be simple, be straightforward, make sure people are understanding you, ask questions. And so there you are. What questions do you have? There should be some sort of comment or chat box available on this. If not, please feel free to send me an email. I'm always happy to respond to any kinds of questions. And thank you for being here. If you're watching this as part of the 2021 IHA Health Literacy Conference, I hope you have a great conference experience. If you're watching this afterward, I hope you had a great experience. At any rate, I hope you learned something, and best of luck in all your future endeavors.